Okay, hi, Cheryl. Hi. For everyone out there, my name is Dr. Jonathan Woolfson. I'm an eye surgeon in Atlanta, Georgia, and I actually have focused my career on laser work and dealing with a disease called keratoconus. And keratoconus is a disease where the cornea, which is the front clear window of the eye, becomes abnormally shaped. It's supposed to be nice and symmetrical, like a basketball or like a perfectly round balloon. And then it tends to get a weak spot in it. And you can think of having a weak spot in the balloon. And in that weak spot, it has some abnormal thinning and bulging. And it's a disease that tends to get worse over time, starts in the teenage years, usually in the second or third decade of life. And then it gets worse and worse, and typically patients need glasses and contact lenses, and ultimately a lot of those patients also need corneal transplants. In fact, in the US, more than half of all the transplants in the US are because of keratoconus.
Jonathan, can I ask a question? I'm sorry for stepping in. So what are their first symptoms, or does somebody notice that they can't see, or do you think it's enough that somebody's going to say, Mom, I'm struggling, I can't see something?
It's a very good question. In the early and mid and even some of the late stages, it is not painful. The eye does not get red, but patients will become more and more dependent on glasses and contact lenses, usually starting off with just being a little bit nearsighted and then getting more and more astigmatism over time. And as a kid, that's, a lot of kids have that who do not have keratoconus, so it's not a big red flag. There is a very easy, non-invasive, quick, cheap test to do at the doctor's office that looks at the shape of the eye that will pick it up very early on, even before it's a major problem. And
is that an ophthalmologist that sees that, or is that like if I'm taking my child to an optometrist, is that a test that I ask them to do?
yes.
Or do they do it at an optometrist office?
Most optometrists now have got this in their offices, and they should, because up until now, there wasn't much we could do for those patients. When they needed glasses or contacts, we did the best we could with glasses, with contacts, with specialty contact lenses, but there's nothing to stop the natural history of the disease. And now we have a very well-established, very safe way of stopping the progression. So the wording is very important, because we're not saying we can fix it or make the vision better, but now we can actually stop it from getting worse. And so it's important to try and catch it early, right? Because if you catch it early, if it's going to get worse and worse like this, you want to catch it when it's really early, so that you can lock in that vision at an early stage, and you can have good vision the rest of your life. And it works more than 99% of the time. One treatment's good for the rest of your life.
Wow.
And so doing these screening tests becomes critical for all patients. In fact, we've been lecturing now for 15 years, trying to get primary eye care doctors, optometrists, and ophthalmologists to do this map testing. Is looking at the shape of the eye. The technical term for it is topography testing. And there are very cheap machines out there. So most eye doctors now have got, if you're going to, anyone getting an eye exam, not just any special subgroups, but anyone getting an eye exam, especially in the younger years, should be asking for that test.
Does a parent ask for the test, or do you think that they will automatically say, is this specific to somebody with Down syndrome, or is this for all kids?
This actually holds true for everyone, but it's a lot more rare in the general population. And it's very different in different kinds of populations. So in the US and in Western Europe, about 1 in 500 or 1 in 1,000 people will have keratoconus. And keratoconus just means, kera just means cornea, and conus just means cone. So it sounds like a fancy word, but it just means the cornea is looking more like a cone than it should. That's all it means.
Okay.
Okay. And so about 1 in 1,000 people get this in the general population. But in certain subgroups of people, especially people that are more prone to having collagen problems, all right, then it's much more prevalent. So people that have Marfan syndrome or Ehlers-Danlos or Down syndrome patients. In the Down community, it is somewhere between 1 in 3 and 1 in 8 people have got
wow.
this.
It's a
So
high number.
yeah. I told you, Cheryl, a while back there it was about 1 in 8 or 10, and there've been a couple of studies now that are showing that it's 1 in 3 of the Down syndrome patients. So we're not exactly sure, but it's in that range. But that's a very much higher incidence than 1 in 1,000 in the general population.
Yeah.
And so, and also, if you have it younger, it tends to be a lot more aggressive and it progresses a lot more. And the ultimate solution for it before we had this treatment was a corneal transplant. And those are things we really try to avoid because it requires a lot of care afterwards. You often need special contacts afterwards. You've got to be on anti-rejection drops. There's a certain percent will get rejected every year, and you've got to make sure that you don't rub the eyes if you have a transplant. Otherwise, you can mess up the whole transplant. And we know, especially patients in the Down community, there's a lot of eye rubbing going on. And so the point is that if we can avoid going down the road of needing a corneal transplant, that is a huge win. And so it's really critical for all kids, but especially Down syndrome patients, to get screening early on. And the general eye doctors can usually do it. If they can't, find yourself an eye doctor who can, because they should be offering this to everyone. And it's really cheap, it's real easy, it's real quick, it's non-invasive, nothing touching the eye. It's essentially just taking a very complicated picture of the front part of the eye. That's all it is. All right. And that way we can identify patients early on and get them treatment and stabilize the cornea and avoid a corneal transplant. And as I said, it's not 100% effective, but it's really close. It's nearly 100% effective on this. And the procedure itself is in 3 basic stages. One is you prepare the front surface cells. Number 2, you put on riboflavin drops, which is a vitamin B2. And then the third thing is you look at a light. So it's fairly simple. There's no cutting, there's no lasers, there's no sutures. There's nothing horribly painful about the procedure itself during the procedure. Right now, there's an FDA way approved way of doing it, and you take off most of the surface cells. And that can be a bit of a problem because it takes better part of a week to heal, and it's very painful. And if you do a lot of eye rubbing during that week, you're going to set the healing process back, and that can be a real problem.
I would say it's almost impossible to expect an individual with Down syndrome.
Correct. And that's why
not do that for a week.
And that's how I got into it. And we'll talk about that later, I guess, was, one of the eye doctors that I know that has a son with Down syndrome approached me and said he really needs the cross-linking, but the way that's FDA approved is not going to work because taking off those surface cells is not good. And so we have an FDA study that keeps those cells on. It's been equally effective. It's more than 99% effective, but it keeps the cells on. And it's looking a little bit painful that night, but by the next morning, most patients are healed. And that's proven to be the best way to do it. And I do think the FDA would approve that mechanism by next year. So we don't know that for sure because it's the FDA and they're going to review the data, but everything is pointing towards getting approval within about a year or so. But the point is that we can now do it by keeping the surface cells on. And that makes a big difference. The drops we put on is just riboflavin drops. It's vitamin B2. If you ever take one of those B complex multivitamins, you ever take those and you start peeing out that yellow-green, that's what riboflavin is. And it's very, very safe, even in very high dosages, whether it's taken as drops on your skin or by mouth. You can take super high dosages, and it's very, very safe. And then the light you look at is just a UV light it's about the same amount of light you get in 1 or 2 days on a sunny day. And that what that does is the light interacts with the riboflavin and starts up a process that makes the cornea stronger and also stiffer. But the point being is that it just stops it from getting worse. It stops it from progressing. So if it has already progressed a lot, then it's most likely going to stop it. You'll be stuck with whatever vision you've got. The FDA way approved of doing it, where you take those surface cells off, means longer healing time, much more painful. But more importantly, there's a small but real chance of getting infection and scarring and corneal melts. And obviously, we really want to stay away from that if at all we can. The cross-linking itself, very brief history of that was figured out by Dr. Theo Seiler in Germany, originally in 1998. If you ever go to the dentist and you get a filling or a mold or something, and then they put that light in your mouth, and it makes the amalgam really hard, that's the exact same process. Because in that amalgam, they've got riboflavin in there, and the light activates the amalgam and makes it really hard. And that's why these days, if you get a filling or something and they use that, they say you can go home and start eating right away. It used to be you had to wait for 8 hours or 12 hours or whatever it was. But now it's hard immediately. And so he was actually at the dentist, and he figured that out. He's like, man, I wonder if we can use that same process on the eye. And so he did. He worked on it, and he first published a paper in 2003. And there was a professor at Emory, Dr. Stelting, who was the editor of the International Cornea Journal. And he got this paper, and he'll tell you, he looked at it and said, man, this is a bunch of BS. This can't possibly work. And then he looked at all the data, and it was really working. And so he actually got involved with bringing it to the United States. And then eventually, he was involved with doing some of the first cross-linking in the US, but it took until 2008 to do, and eventually it got approved, I think somewhere around 2010, in that range, to 2016, I think it was actually, that eventually got approved. But we knew early on that taking those surface cells off was a problem, and we started in 2000, I think it was 2013. We started doing where we modified the riboflavin with some other medications and kept the surface cells on. And we went through the FDA, so it's a fully approved by the FDA trial. We changed the light source as well. We changed the riboflavin. We changed what we do to the front part of the eye. So the basics are the same, but each one of the components we changed around a little bit. And so since then, we've done a few thousand cases and had really good success with it.
Excuse me once.
Hey, no worries. I'm a huge dog lover, so I totally get it.
Little commercial. She's been playing with herself all afternoon. Okay. So
anyway, so that was the brief history of the cross-linking. Around the world, it is absolutely the standard of care. And they've been doing it now in Europe for a lot more years. And they've seen a huge decline in the number of corneal transplants. In fact,
and are they doing it around the world for people with Down syndrome as well?
Yeah. So they're doing around the world for everyone who's got keratoconus. And the number of transplants, corneal transplants in Europe, has now decreased by more than half because of this procedure. Wow. And now obviously people get corneal transplants for other reasons, but this was responsible for more than half of all the transplants. And now the number of people in Europe getting transplants because of keratoconus is minuscule. It's really people that have just slipped through the cracks. So
here you said that now I can only see your eyes.
Sorry, what's that?
You need to pull your screen down. I can only see your eyes. There you go.
There you go.
Yes. So you had said I thought you had said that it was FDA approved. It's not yet approved by the FDA?
The mechanism is approved by the FDA, and that's the way that we use when we take the surface cells off. That's approved
Okay.
by the FDA. We do that every week. But in addition to that, we have a way of doing it where we can keep the surface cells on. And most of our patients choose that.
Okay.
Okay, so there's two different ways of doing it. And I've got a little video. I think in that video I sent you, Cheryl, it kind of explains the two different ways of doing it.
Okay.
We treat patients that are very young. In our study, we'll treat patients that are as young as 8 years old. And we haven't had a lot of 8-year-olds, but we have had several patients that are 10 and 12, had a lot of those. And to me, that's the most gratifying thing, because we know that patients with that, because patients that age with the disease, we know it's going to be a lot more aggressive, and they're going to need a corneal transplant real early. And if they need an early transplant, there's a much higher chance of rejection and losing their eye ultimately. And so it's been very, very good to be able to offer that to those patients. And we've stayed away from the serious complications that the other way has, in terms of infections and scarring and corneal melts.
So you're doing this currently, right?
Yep.
You're doing it currently. So, and it's not covered by insurance. Is that right? Currently?
The way that is FDA approved is covered by insurance. And so, if the finances are an issue, most people may go for that option. But I know, like in Georgia, the average co-pays and other costs are really high. I think in Georgia, it's, I think you pay the first 6,000 or 7,000 on average, depending obviously on the plan and the insurance company. But yeah, it is covered by insurance. And the FDA study is not, because no studies are ever covered by insurance. Right. But we can actually do the study for a lot less, but it is a very expensive procedure. The one that's FDA approved, just the drops alone cost us just a little under $4,500 per eye. So the whole procedure is very expensive. Our study, we can do it for a lot less because we can actually get the drops for less money. So it is complicated paying for it. We try and help patients out as much as we can in that regard. So
as long as somebody can help them kind of identify. I mean, obviously, they're going to want this, but now we have to figure out how to help them pay for it, and that might be something that DSAA can research as well with some of the other groups that we work with.
Yeah, and we have a team that helps patients with that, and
perfect.
In certain cases, we'll donate some of our services in certain cases as well. But the one that's FDA approved at $4,500 per eye for the drops, we've got to figure a way to kind of get over that.
So how do we get the word out to the optometrist? Because I was telling you earlier that we had this, just as this conversation has come up, we had a colleague that mentioned to another woman that he hasn't seen in a long time, and they were just having a conversation, and he said, make sure that you ask about this. She had never heard of it. And I think, we talked about it. A lot of our families are not educated about this at all. There's so many other things, unfortunately, that they have to sort of worry about. And if it's not affecting them at that moment, then they don't even think about it. So if it happens in their teen years or early 20s, so he just happened to mention it to his colleague. She took her daughter to the doctor that next week, and she had it. And said that she never would have known, because nobody's ever, and her daughter's like in her late teens, nobody had ever mentioned it to her before. So how do we get the word out?
Well, that's something the two of us have to work on together. I've certainly got that word out to the eye community. We do a lot of lectures to eye doctors. Just about every week, I'm lecturing somewhere in the Southeast. I had a lecture earlier this week in Knoxville. The week before that, I had a group of, I think, 30 or 40 doctors in Chattanooga. And in the Atlanta community, we have multiple lectures every quarter. And it doesn't matter what we're lecturing on, because we're not always lecturing on keratoconus. We may be talking about other things, but even if we're not talking about keratoconus, I always mention it to the eye doctors. And as I said earlier, it's not just patients with Down syndrome, it's all young patients need to get checked for it, because if you can catch this early, there are very few things that are this safe to do that can have such a huge impact on people's lives.
I mean, it just doesn't make any sense.
Because if
I
you
mean, I
catch
know
it
that the other
early,
numbers are 1 in 1,000, but 1 in 3 is it's pretty alarming.
yeah, it's somewhere between 1 in 3 and 1 in 8 is our best guess right now for the Downs community. And so, yeah, we're talking to the eye doctors about it, but I think there's certain things within your organization you're doing, and eventually we'll get the word out. And when we have events or galas, and, you know, we don't mind getting some of our staff out there, and we can do some screenings at events as well.
That would be great.
Because, yeah, because those machines are pretty easy to move around. And so we could set up a little booth and do screenings real quick. And even if you don't get a lot of people involved, at least you're creating some sort of buzz about it, you know. So, you know, people would at least be talking about it.
That you just spoke my language. So we have some events coming up that might be just exactly what we do. We've done that for hearing screenings for Emory and a few other options. So because we want to get it out to everybody, and we have a lot of people from the underserved populations, and I want to make sure that everybody has the same opportunity for any of this. So that would be amazing, actually.
Yeah, and as I said, it is really expensive, and I've actually set aside a chunk of money from our own clinic, and then we also will put some clinic resources into it as well, to be able to try and help people from the underserved community. Obviously, there'll be a limit to what we can do because the costs are so high, but we've already set aside a big chunk of money to help with this. We've got a team that's real passionate about helping these patients.
Okay.
And so as we get the word out more, I think it'll become one of the standard screening issues that pediatricians should be checking.
Absolutely.
You know.
And is that something that could go into a pediatrician's office versus an optometrist?
I mean, it could, but they're unlikely to do that because they're not going to feel comfortable, you know, making that diagnosis or reading the scans. Right. Although it would be very easy to use because, as I said earlier, it's non-invasive. It's really looking at a camera and it's point and shoot and click, and it would be possible.
It's just with a lot of our families, you know, if they go to the doctor, I don't get them all to the optometrist.
That's
right.
right.
So I was just trying to save a.
I think the yield would be so low at a pediatrician's office.
Yeah.
That they're not going to be likely to want to do that. Okay. So.
Okay, well, is there anything else that you think that people have to know, or?
No, I would just highly recommend all the kids get checked with it, especially any.
And when do they start checking for that?
You know, I would start checking for it by age 8.
By age 8, okay.
You know, I've got some family members that have got keratoconus, and so I check my kids at age 8, and I check them every year. So.
Awesome. Okay. Well, I think that, I mean, it's, you know, we're actually trying to devise something that kind of says, you know, when to start checking on things. And so I can certainly add that to the wins and it's not just the developmental stages, it's kind of the red flags. And I'm assuming that they would notice. And, you know, I'm thinking that most of, like really thinking about it, but most of the people that we work with all wear glasses and have done it from a young age. So I'm hoping that they're all being checked for it. Now, is it ever too late? Is it to diagnose this? Is it like if you're in your 20s, it's too late and there's nothing you can do, or?
No, we treat patients even in their 30s and 40s. It's more an issue of if there's been a lot of damage to the eye already, and if there's a lot of scarring and there's not much useful vision left, then at that point, there may not be enough vision to save. Because you could still do the cross-linking, but it may not make sense because if you don't have functional vision to save, then we should, what are you actually doing? What are you saving?
Right. I mean, if it's so bad.
But that's very far along. the line. And even then, we've had some patients that we treated with cross-linking that we thought were too far along the line, and they regained some functional vision and chose not to have a transplant. So,
Okay. Okay.
so most patients that have this really need to get done and get it done as quickly as possible. I saw a patient this morning actually, who's a pilot in the Air Force, and he just got diagnosed with keratoconus.
Oh, really? Wow.
And he's just starting to lose a little bit of vision. If you lose much more vision, they're not going to let him fly.
He's not gonna, I was gonna,
So
isn't
he's
that one of
like,
the first things to
when
go?
can you get me in? And I'm like, dude, I'll get you in as soon as you're ready and everything. And so we may
Yeah.
even come in this
Wow.
weekend and just do them this weekend
Wow.
because,
Do people come in from all over the world for you?
yeah, we've had people, we've really become a big referral center for this. And so we're doing a lot of this, and we're keeping up with what I think is the best way to do this. And that's one of the advantages of doing this study. You see, part of the problem with the FDA is that it takes so long to get everything approved. So the way that it's FDA approved now is still the exact same protocol that was done in 1998. It's called the Dresden Protocol because it was figured out by this surgeon in Dresden, Germany. And so the way that we're doing things now under that's FDA approved is something he figured out as his first best guess of how to do this in 1998. And so since then, as a community, we've learned a lot about this, and we've, as I said, every step of the way, preparing the front surface of the cells, the actual drops themselves, and the light itself, all of those have changed significantly in order to get better results. But it takes so long to get through the FDA process, so that even when this next rendition gets approved, it'll be something that we were doing, 5 or 10 years ago. And so it's very hard for them to keep up because it takes so long to get approval.
Oh,
So
I'll
that's
hold my.
part of the reason why we have our FDA studies on the side to try and to fine tune the best way to do this and see which ones are working the best, which changes to the protocols are working better. But all of the ones that we're looking at are proving, I believe, to be so far they've proved to be better than what the ones that are FDA approved is doing.
Well, the way you described the surgery prior to, I can't even imagine. And I couldn't imagine myself going through it. So I certainly can't think of any of our individuals that would go through it successfully.
Yeah.
So, is there
Okay,
anything else that you?
Nope, we're happy to help out, and if you have any events, we have a lot of.
I want to set up a screening. Now you get me all. I'm all excited about the possibility of doing that, and we'll talk about that because we have some dates.
Yeah,
I
and if
told
you
you
have
about
anything
one,
else like a fun run or anything else that you guys organize,
October 4th. We'll
yeah,
see you on October 4th.
yeah.
That's our big walk.
All right, we'll have a booth
So
there.
we would love to have, but I mean, that would be amazing if we could do screenings there.
Yeah.
I mean, because we have them as young as 8 and as old as 30 or 40. So you would have a good group in there to do it. And again, as I've discussed this with other people, I've been doing this. I've been in the field for a long time, and I never heard of it until you told me about it a couple of years ago. And because I just didn't, for all the people that I know, I'd never really had anybody say that out loud, or if they did, I didn't hear it.
Yep.
And to know that we have you sitting in our backyard in Atlanta, Georgia is a pretty big deal. So,
Well, great. It was great to talk to you. We're happy to get involved. Just
right.
let me know how we can help out, okay?
October 4th.
I got it on my calendar, October 4th.
Okay. Thank you so much. And I appreciate you coming on today. See you
Take care,
later.
Joe. Cheers.
Bye.
Bye.